presenting patient, gathering clues in the history, checking out the physical evidence, establishing the verdict and staging, and finally, laying out the treatment plan.
Section 1, the presenting patient. Let's meet our lead suspect. So, our patient is a 36-year-old gentleman, but the absolute most critical number here is 15. He's been a chronic tobacco chewer for 15 years, and he smokes half a bundle of biddies a day. Listen, if you're presenting this case, stating this upfront immediately impresses your examiner. It shows you're already thinking in a very specific direction, you know you're likely dealing with a malignancy, and you're establishing those definitive risk factors before you even describe the lesion itself.
Moving to his presenting symptoms, we're looking at an insidious onset over the last 2 months. But here's the major red flag. The lesion is rapidly progressive. That phrasing strongly hints at malignancy. Because this is a raw, ulcerated area in the mouth, the guy experiences a severe burning sensation, especially with spicy foods. And to top it off, the friable nature of this raw tissue has actually led to 2 recent episodes of mild bleeding.
Let's move to Section 2, gathering clues from the history. In clinical medicine, what the patient doesn't have is literally just as vital as what they do have. The negative history is exactly how we rule out our differential diagnoses. So why do we care about these specific negatives? Well, we ask about dental intervention or dentures to rule out a lesion caused by chronic mechanical irritation. We check for loosening of teeth because if the mandible or maxilla is involved, those bony structures are compromised, which makes the teeth loose. We ask about multiple sexual partners because, believe it or not, secondary syphilis can actually present just like oral cancer. And finally, we rule out headaches, bone pain, seizures, and jaundice. These negative findings help us confidently rule out distant metastasis right out of the gate. All right, Section 3, the physical evidence. Before we even look inside the mouth, we have to look at the patient as a whole. A massive tumor means absolutely nothing if the patient's body can't withstand the surgical takedown. Now, what's really interesting about this slide is how we objectively measure a patient's functional status using these performance scales. You've basically got 2 primary tools here. The Karnofsky index ranges from 100, which is perfectly normal, all the way down to 10, meaning morbid or fatal. On the flip side, the ECOG score inverts this. It runs from 0 for asymptomatic down to 5 for death. These scales give us a quick read on whether the patient is bedridden or up and about, capable of daily activities. For our patient, he scores a 90 on the Karnofsky index. He's alert, conscious, cooperative, and has adequate nutritional and hydration status. This essentially proves he's fully functional, capable of normal activity, and most importantly, physically fit enough to undergo a major, demanding surgery. Now we finally look into the oral cavity. We note normal dentition with tobacco staining, sure, but we also spot multiple leukoplakic and melanoplakic patches. This brings up a really vital concept, field cancerization. Because this patient has literally bathed his entire oral mucosa in carcinogens for 15 years, the entire area is preconditioned for cancer. Those dark and white patches, they're premalignant. They signal a really high risk that multiple completely independent cancers could pop up in this exact same oral cavity down the road. Let's zero in on the primary suspect, the lesion itself. It's a massive 5 by 5 centimeter ulceroproliferative growth on the left buccal mucosa. It spans all the way from the second molar and stops just short of the retromolar trigone. When we palpate it, we feel a necrotic base. It's got those classic well-defined verted edges, and fortunately for us, it doesn't actively bleed on touch. We also really need to evaluate the cranial nerves. This builds our understanding of the tumor's depth and invasion. The patient's facial symmetry is perfectly maintained, so we can rule out facial nerve involvement. The uvula elevates right in the midline, the tongue protrudes straight without any deviation, and he can lift his tongue straight up to the hard palate. This brilliant, rapid clinical exam confirms that cranial nerves 9, 10, 11, and 12 are completely intact. The tumor hasn't invaded those deep, critical neural structures, which is a huge relief. Section 4, the verdict and staging. We've gathered the history, mapped the physical evidence, and ruled out deep nerve involvement. If the attending physician turns to you right now and asks for your summary, you don't just awkwardly list facts. You deliver a 3-line, punchy synthesis. You have a 36-year-old chronic tobacco chewer with a rapidly progressive 5-centimeter ulceroproliferative lesion on the left buccal mucosa, a single mobile lymph node in the neck at level 1B, and no clinical involvement of the cranial nerves. So what is the precise clinical impression? The verdict is an unequivocal clinical malignancy of the left buccal mucosa. And the exact staging? It's T3N1MX. And this brilliantly illustrates how we translate physical findings into the global TNM language. The tumor is 5 by 5 centimeters. Because it's larger than 4 centimeters, boom, it's automatically a T3. The patient has a single mobile lymph node measuring 1.5 by 1 centimeter. Since it's a single node, 3 centimeters or smaller, that's N1. Finally, why do we say MX instead of M0? Because without a full-body scan, we simply cannot definitively assess distant metastasis purely by clinical touch and sight. Stating MX shows you're attending, you completely understand the limits of a physical exam.
Section 5. The treatment plan. We have our target, we have our stage, now we execute. How are we taking this malignancy down? First things first, we have to histologically confirm our clinical suspicions. So, do we do an excisional or an incisional biopsy? For a massive 5-centimeter lesion like this, we never do an excisional biopsy initially. We absolutely rely on an incisional wedge biopsy. We take this tissue strictly from the margin, the exact junction where the normal tissue meets the abnormal necrotic tissue. That's going to give us the absolute most accurate cellular read possible. Once confirmed, here is our 4-step battle plan. Step 1. A diagnostic contrast-enhanced CT scan of the paranasal sinuses, neck, and thorax to properly stage the disease internally. Step 2. A wide local excision of the oral lesion itself. Step 3. Because of that N1 node, we're doing a modified radical neck dissection on the same side. And Step 4. We have to rebuild what we take away. We'll use a pectoralis major myocutaneous, or PMMC flap, for reconstruction. To make sure literally no detail is missed, let's go over the surgical action details. When performing the wide local excision, we absolutely require at least a 0.5 centimeter clear, healthy tissue margin around the tumor. To access the neck for the dissection, we'll utilize a modified Schobinger's incision, which gives us wide, clear access to those nodal basins. Finally, our job isn't done just because we close the flap. If the final histopathology report shows that those extracted lymph nodes are indeed positive for cancer, this patient will be mandated to undergo postoperative chemoradiation. We've gone from a patient's smoking history to a high-level reconstructive surgical plan in just minutes. It just goes to show that when you approach a case systematically, the clues practically solve the mystery for you. You don't just see a random ulcer anymore. You see cranial nerve pathways, field cancerization, and nodal spread. So I'll leave you with this. As a clinical detective, what small, seemingly insignificant detail will you look for first when evaluating your very next patient? Keep your eyes sharp, trust the structure, and I'll catch you in the next explainer.